Everyone that's here, thank you so much for joining us. We want to talk about a very cool topic that is really important because so many of us are in this situation. And it's basically trying to address this kind of problem that is so prevalent, it's kind of scary. It's this nagging back pain that's greatly affecting your function and quality of life, not to the point where you're willing to have a big disruptive procedure like a fusion surgery, but bad enough that it's affecting your career, your relationships, and your overall psyche, because life is short and bored people get very, very cranky. So I have today a very special pair of guests. Right now, are you guys seeing one screen or two screens with a little thing?
Two screens with a little thing.
Okay.
Two screens.
I got to switch this.
Yep, there you go.
All right, so I'd like to introduce Dr. Chris Rogers and Dr. Annette Ambach. I've known Dr. Rogers since I was a resident at UCSD, where he was a junior attending when I was a senior and chief resident. So we know each other really well. And Dr. Ambach, even though she looks like she just graduated high school, she's been around for a really long time. And I've known her since 2008. So these are one of my two favorite pain colleagues that I work with frequently, and they're also experts in regenerative medicine. So this is the field of medicine that goes above and beyond just doing epidural steroid injections and utilizing things like stem cells and PRP. And I have a lot of patients asking me about that. And so I want to talk about that a lot today, because that's something that I don't know a lot about either. And I think that is going to be a really big component of treating this group of patients that have failed traditional treatment and is just smoldering along. I'm hoping we don't talk too much and we have lots of time for questions. So in that regard, if you look, for all the people that are attending, if you look at the bottom of your Zoom screen, you'll see something that says chat. If you click on that, you can start typing in chat. Lana, sitting right next to me, is looking at the chat. And while I'm talking, Dr. Rogers and Dr. Ambach will be looking at the chat and either interrupting me with a question or answering the questions on the chat themselves. And then two, when you go to your Zoom screen, go to the top and do a couple of things. One, first of all, don't forget to hit the chat button so it opens up a little dialog box on the side. Go to the top of your Zoom screen, and when it says Zoom options, go down and check the side-by-side mode so that you can see the panelists, the chat box, as well as the share screen. And there's probably one other thing, but I can't remember. All right, so here is like the clinical scenario. Nagging low back pain is unbelievably common and significant. I'm sure you guys are like, no duh, that's why I'm here. It turns out at some point, most adults will have this problem at some point in their lives, and a lot of them will have it chronically. So 90% of the 75% resolves in 6 weeks, but there's still the 10% of the 75%. That's still 7.5% of all adults potentially will have some degree of nagging chronic low back pain. Not all of them will be to the point where they're needing treatment, but a lot will have this. And if we can take care of those patients, it would be a major thing to take care of, because it is a really big burden, not only on the poor person that has this problem, but in terms of society and the field of medical care in general, because it's the second most common reason why people go to their doctors for their visit. The most common is an upper respiratory tract infection, a common cold. But it's the #1 cause of work and disability, of work loss and disability. So depending on if you're the employer or the employee, either way, it's a big hit. So if you ask, okay, this group of patients, where is their pain coming from? Look at this chart. You're going to be shocked. So see this pie chart? This huge blue area? Guess what that's considered? This is from medical journals. It is considered non-specific low back pain. So if you have cancer, a compression fracture, all these other specific diagnoses, you can go after treating this problem if you need to. But if you have a diagnosis of non-specific low back pain, where do you go? What do you treat? How do you effectively manage a patient like that? And this is probably one of the reasons why we have a big problem. We've just kind of decided, okay, I don't know what it is due to. I don't want to know. And who cares? but I think in today's society, we care about quality of life. Now, if you look at the actual anatomic structures, you can get more specific. And I like looking at it like this more. It's not a diagnosis of disease, but the identification of a structure in your back that generates pain. So the disc can cause pain, the ligaments around the spine can cause pain, the bones can cause pain. I think that's obvious. Even the muscles can cause pain. Anybody that's had a calf or a hamstring cramp will know how painful a muscle cramp is. Now imagine one of the most powerful muscles in the body, the multifidus muscle that's in your low back, that develops a cramp. Very painful. There's also, other structures, but those are the main ones. So now if you're starting to look at anatomic structures, now we can start asking, how can we treat a disc problem? How can we treat a facet problem? How can we treat a ligament problem? Now we can get somewhere. And if you don't do that, you can't really attack this problem. Now, the people that I'm talking about, the group of patients that have this nagging, ongoing chronic back pain, that's not them. They've already gone through this process. They've had medical management. They've seen their primary care doctor. They've been told, oh, go to take some medicines, avoid this and avoid that. They've gone to physical therapy and that's not worked. So they go back to the primary care doctor and the primary care doctor sends them to pain management. Pain management adds in bigger medicines, institutes bigger treatments, including injections. A common thing would be epidural steroid injections. And then if that doesn't work, you get sent off for surgery and a patient like this gets told the following. Well, really the only thing we could do for a problem like this is probably to do a fusion surgery. It'll probably take 3 to 6 months to recover. And it's a big deal, there's gonna be a lot of pain. So of those patients, the majority of them say something like, oh, well, it's not that bad. I guess I'll just go home and suck it up. Because we don't have, and I'll talk about it very briefly, but until recently, patients with chronic low back pain, if they had surgery, it was almost always a fusion surgery, which is massive. So you have a patient that says, I cannot have a fusion surgery. I will lose my job and I've got a family to take care of. They're busy working. Their pain's been around for a year. They've modified their workstation. They've changed their lifestyle so they avoid a lot of things that cause pain, including things that they love and bring joy to their life and quality of life. And they tried all these things. They're not willing to have a fusion. They have this imaging finding. So this for people, and it's not important exactly what the diagnosis is, but that it's what looks like a relatively mild abnormality. We call this a disc bulge with an annular tear. Lots of people have it. And here's the crazy thing. If you take 100 people off the street, a bunch of them will have annular tears and not know it. So they may be told that's just an annular tear, that shouldn't cause pain. But that's not really true. Even though most annular tears do not cause pain, it is absolutely clear that a small proportion of patients will have an annular tear and it will be painful. So our burden is to not just say most people do not have symptoms from an annular tear, because the person that does have an annular tear is sitting there going, but I'm not one person, so for me it's 100% likely that it's causing it. So if we can identify that patient, and it's our kind of burden, responsibility to identify the patient, if we can do that, we can help a large group of patients that have been smoldering along. So I'd like to now throw out this patient, of which there are a sea of them. What else can be done? And that's why Dr. Rogers and Dr. Ambach is here, because they're the type of people that are kind of looking to the next level to try to figure out what else can be done besides all the things that we already have in store. Because there's a bunch of people that have tried PT, chiro, acupuncture, epidural steroid injections, activity modification, pen medications, exercise, and they're still having trouble. So with that, I'd like to introduce Dr. Ambach and Dr. Rogers. And Dr. Ambach, I'm gonna stop the screen share. I already did. And have you pull up your slides. So once again, I want to remind everybody, please use the chat feature and ask questions so that while Dr. Ambach and Dr. Rogers are talking, I'll try to answer questions. And if it's a brilliant question, I'll interrupt them. Because we don't like talking on and on and on, thinking everyone's asleep. Sound good?
Thanks, Dr. Kim.
and thank you for coming on board.
Hi, everyone.
So good to be here with you. Really great that you're putting this program together and happy to participate. We're going to talk about those treatments that you were referring to for chronic low back pain. This could apply to other parts of the spine as well, but we're going to focus on the lower back today. Maybe in the future, we'll do some lectures on other parts of the spine. So I'm Chris Rogers. Dr. Ambach is my partner. We have a medical practice in Carlsbad here, California. Dr. Ambach's controlling the slides, so you'll hear me ask her to advance to the next slide. We have a practice called San Diego Orthobiologics Medical Group, and I'll tell you later what an orthobiologic is. Let's go to the next slide. I'm board certified in physical medicine and rehabilitation. As Dr. Kim mentioned, I worked with him when we were at UCSD together in the Department of Orthopedics. Very progressive. They actually invited a non-surgeon spine specialist to come join and help train the residents, and that was a great experience. Actually, I think I learned more than the residents did. Then I went into private practice a few years later. I am also fellowship trained in interventional spine procedures, which means I took a year after residency to learn how to inject various parts of the spine. Dr. Ambach also has similar training. And in addition, she has advanced training in what's called regenerative medicine, fellowship training in regenerative medicine. Regenerative medicine is an evolving field that just means that we're figuring out how the body heals itself naturally, and we're trying to use those discoveries to create new treatment options and translating that science. I've been in practice for more than 23 years. Dr. Ambach, I think you've been in practice for what, 14 years now?
15 years.
So we've seen 15. So we've seen lots of folks with spine pain. We're academics. We like to publish. We participate in research. We're actually involved in a FDA-approved clinical trial right now using stem cell therapy for osteoarthritis in the knee. And Dr. Ambach is involved in a multi-center randomized controlled trial using cell therapy for disc degeneration, so very relevant to this talk. Next slide. So just a real quick anatomy review. You know, we have the spine. We're going to go down and take a look at that lumbar spine. And down there are a lot of things that can cause pain, but we're going to focus on the disc today. The intervertebral disc is really made of two parts. You have that outer annulus, fibrous part, and the inner jelly. And if it disrupts, it can bulge and pinch the nerve. But more commonly, we see that outer annulus will crack or tear. That's what Dr. Kim was talking about. And the reason we get these is because, unfortunately, we get old. And according to Mother Nature, 40 is old. When you're 40, those little cells that live in that jelly center, they start to die. And you need those cells because they make the jelly. They make something called aggregin, which attracts water, which makes that nice juicy center. But when that juicy center starts to dry out, the disc will start to flatten. And then those layers, that annulus, there's laminated layers, will start to bulge and crack. And that's painful because there's a nerve supply that goes to that outer part of the disc. And the body tries to heal it. It grows blood vessels in there and it grows nerves in there, which unfortunately makes you feel that pain even more clearly. So this is kind of like a chronic wound that just doesn't heal. You can imagine a wound on your skin. If it didn't heal, just be really sore. The only difference is it happens to be right in the middle of your body, which you're going to be using all the time when you're sitting, bending, lifting. And Dr. Kim mentioned that a lot of people have these tears on their MRI and they don't have pain. And the rest of the story is they don't have pain yet. They're one sneeze away, one cough away, one bad move away from getting back pain. And we've seen that published in the literature. Next slide. So again, here's that picture of the MRI. And you see the healthy discs up above that have that nice white juicy center. The one at the bottom is a little darker because it doesn't have as much water in the disc. And then it's got a little bright white signal that signifies fluid in a tear. Next slide. The disc degenerates. It's just a fact of life. We get gray hair, we get wrinkles, and we get disc degeneration. That's just, sorry, that's a little foreshadow, but that's our future. And on the left, you can see what a nice healthy disc looks like. It's got that nice bright center. As you go to the right, it gets darker and darker. As you have less water in the jelly, it loses its height. And then it starts degenerating and bulging. And becomes painful. Next slide. So, you know, for years we've had physical therapy, we've had back braces, we've had different types of cortisone shots and things like this. And, you know, I did that for 15 or so years. And I got really excited when somebody came into my office about 12 years ago and showed an MRI of a guy's spine that actually looked better a year later, not worse. And that kind of blew my mind. I'd never seen anybody's MRI look better the next year. It always went the other way around. And they had had an orthobiologic treatment. They had had some cells injected into their disc. So I decided I'm going to travel all around the world and learn more about this. And so the collective term is called an orthobiologic. It just means a cellular or cell-based therapy that we use in orthopedics. And we use these because it can help heal tissues. And these are some of the ones you may have heard of. Platelets, like PRP, platelet-rich plasma. Stem cell therapy, I think people have heard about. Growth factors and cytokines and proteins, maybe not heard about, but these are some molecules that have been shown to be helpful for healing, as well as fibrin, which is a protein in your blood that we can use for disc tears. Next slide. Now the FDA has something to say about this. They control every drug in the United States. Every drug in your medicine cabinet's been approved by the FDA. But then there are certain things that are not covered by the FDA. So if you're, for example, if your surgeon takes a tendon out of one part of your body and puts it somewhere else, that's permitted through the practice of medicine. And the same is true if we use cells from your blood, such as platelet-rich plasma, or cells from your bone marrow, such as bone marrow concentrate. And the FDA has these guidelines that we have to follow as physicians so that we make sure we're doing things safely. And that's different than getting an FDA approval for a drug. Next slide. So what is platelet-rich plasma? Well, you may have heard we take your blood and we centrifuge it, and this separates the layers. So at the bottom there, you see the red blood cells, which are responsible for transporting oxygen and carbon dioxide. At the top, you have this stuff called plasma. Whatever you had for breakfast is floating around in that plasma. So I hope it was something good. And then in the platelets, that middle layer, that white layer, that's where we're concentrating, because your blood is really only about 1% platelet cells. So we have to concentrate the blood to get that platelet count higher. We like the platelets because they produce molecules that we call growth factors. And there's thousands of them, and they do different things. And the best way to think about them is think about them as a fertilizer. They're gonna fertilize the seeds and help the plants grow. So they can help cells to proliferate. They can cause new blood vessels to form. They can cause tissue regeneration, and they can also decrease inflammation. Next slide. A point I'd like to make is that not all PRP is the same. And we see this all the time. In San Diego, there's probably 20 doctors that offer PRP therapy. And you just need to know as a patient that you're not getting the same thing at every clinic. On the left, you have the cranberry flavor. In the middle, you have the orange juice flavor. And on the right, you have the pineapple flavor. And they each have different properties. The one on the left is red because it's got a lot of red blood cells in it. Whereas the one on the right is yellow, doesn't really have much red blood cell in it. It has mostly plasma. And so we use different types of PRP for different kinds of problems that we might treat. For example, we really don't like putting PRP that has a lot of red blood cells or white blood cells into your joints, say if you have knee arthritis. And there's some studies that show that if you culture disc cells in the petri dish in the lab with the cranberry flavor, they don't do as well as if you culture them with the pineapple flavor. So that's important to know. Next slide. A friend of ours, orthopedic physician in Marseille, France, did this study where he donated his blood and invited 8 different companies to bring their centrifuge machines and bring their protocols and make their brand of PRP out of his blood. And so you can just tell by looking at it, they all look completely different. You got some really bloody stuff, and then you've got some really nice clear stuff. And then when you do a cellular analysis, you can just imagine that the platelet concentrations vary widely, the red blood cell concentrations vary widely, and the white blood cell concentrations vary widely from one system to the next. So you really need to know what the heck you're doing. Next. Okay, so that's platelets. Stem cells.
Are you going to tell us which one you used the most?
We use all of them. Depends on what we're treating. For the disc, we're going to put that pineapple flavor in your disc. The disc like it. Very powerful anti-inflammatory, and also has a high platelet concentrate, which is good for those nucleus cells and that annulus, that outer annulus cells. Now I'd like to briefly talk about stem cell therapy. This is a huge topic. You learned in high school that cells go through mitosis and they divide. Stem cells are cool because your skin cell can only become 2 skin cells, but your stem cell can do a lot more than that. When it divides, it can make a copy of itself, or depending on where it lives, it can make a completely different kind of cell. So a stem cell could turn into a bone cell, for example. And when this was first discovered, next slide, when this was first discovered in the 90s by this guy, Dr. Arnold Kaplan, a professor at Case Western, oh my gosh, just bells went off in his head. He said, oh my gosh, here we go, a new medicine, the mesenchymal stem cell. It turns into all these different orthopedic tissues, bone, cartilage, nerve, muscle. These are things that orthopedic surgeons would love to have. And so that's where we thought we were going with this. But now, 20 plus years later, we learned it's actually much more complicated than this. Next slide.
Can I just throw in a clarifying point? So he changed gears here. So PRP doesn't have any cells, so it's kind of like the juice that helps the regenerative repair process, right?
It has cells. It has platelet cells, but they're different than stem cells.
Right. They're helping the body get better. Where stem cells are providing some additional cells to replace the existing cells that are missing in a degenerated disc. So kind of 2 different ways to attack the problem. Is that fair to say?
It is, and I think the key there are probably more similarities than differences. For example, in this slide, you see those little pink cells? They're just sleeping on the blood vessels, that little electron micrograph. And they're just sleeping. And you have this in every tissue in your body. You have them right now. If you didn't have them, you'd be dead. And those little stem cells are sleeping. And then you stub your toe and they jump off the blood vessel, they head down to your toe, and then they release all these molecules, which are, some of them are growth factors that will cause tissue healing and decreasing inflammation. And then they have a lot of other cool stuff they do. Platelets kind of do the same thing. They'll release molecules as well. But the difference is the stem cell is going to hang out a lot longer than that platelet cell. That platelet is probably going to hang out for about 14 days when we inject it into our patient. The stem cell is going to hang around for several months. And that's why we think perhaps stem cells are more valuable for the more severe injuries, where PRP is better for the milder injuries. Let's go and get the next slide. So again, how does cell therapy help for discs? Well, it causes those cells, which are decreasing in number, to start replicating again. And then those cells start manufacturing proteins that are important, like collagen and aggregan. And that then causes the nucleus of the disc to get hydrated again, and then decrease the inflammation, which obviously irritates your nerves and makes you cranky. And then it also makes the disc a little bit stiffer and more solid. Anybody who's had a herniated disc or a disc tear, and I'm with you, I've had a disc, I actually have 4 herniated discs, will tell you if you bend the wrong way, your back will go into spasm. And the spasm's actually there to protect you. Your body is saying, oh my God, this disc sucks. This disc is causing the spine to fall apart. The disc is not just a cushion, it's actually a ligament holding your bones together. If it's not doing a good job, your muscles are like, all right, disc is doing a bad job. I guess I need to spasm to create some stiffness and tell this guy to stop doing what he's doing. Next slide. Okay, this is a busy slide, but I'm gonna spend some time here because I want you guys to get the concept that not all stem cells are the same. Oh my God, how many people have seen billboards? Have you ever driven through Florida? Like every 5 miles, there's a billboard for a stem cell clinic. So I really want you as a patient to understand the difference between what I'll call science and science fiction. So on the left, you have science. So there's a company called Mesoblast. Dr. Kim's heard of them. They manufacture a stem cell that they grow in the lab. See that guy in the bunny suit? He's growing cells in the lab to the tune of about 6 million stem cells. And they are now in what's called a phase 3 clinical trial where they're injecting these cells into the disc. You can't buy this on the street. You have to be a patient enrolled in this FDA-approved clinical trial to get this. If they prove that this cell is good for treating back pain, they will have an FDA-approved drug that any doctor in America can use. That may
Let me
come out.
let me just chime in real quick. So the reason why you have so many different, and correct me if I'm wrong, so many different options on stem cell therapy is that the FDA works in a funny way. If you take your own tissue, like your own blood, and you minimally manipulate it, like spin it down and try to get some stem cells out of it, like 20,000 stem cells and some platelets, and put it back in the body, it's an autograft or autologous transplantation. It does not have to be specifically FDA approved because it's your own tissue taken out, minimally manipulated, and put back into you. As soon as you manipulate it more than minimal, and there's a gray line, or you start using cells from somebody else to populate somebody else's disc, then it goes under the purview of the FDA. So what does that mean? That means that even without a lot of testing and FDA approval, I, as a physician, could just go, I'm gonna take blood from you, isolate as many stem cells from you as possible, and put it back in, and we'll see what happens. So if anyone's wondering, why is there so many out there, and why is there this one company that has to go through the FDA trial, and why can't I have that right now like I have the other ones? That's the reason. It's some funny nuance of how the FDA says it's okay to use a medical product and when it's not. And it's in this funny kind of gray area right now where autologous tissues are not under the purview of the FDA. That's still true, right?
The FDA is very smart about this. They want us to be safe. So that's why you have to go through this rigorous process.
For the mesoblast, for example, stem cells.
That's right.
Not
That's right.
the one in the middle, right?
By the way, that mesoblast cell, that's not your cell. That's a donor cell. So some healthy person donated their bone marrow, and then from about 1 million cells, they grew them in the lab in those little pink dishes. They fertilize them, they talk nice, and they grow about 1 billion cells. And then they bottle them, and then for their clinical studies, they study them. So these are donor cells. The FDA is very concerned about putting a donor cell into your body, somebody else's DNA, RNA, God knows what else, into your body. That needs to be studied for safety, and it needs to be studied for effectiveness before they are going to give you that stamp of approval, that FDA approval. Now that's completely different than the middle column there, which is bone marrow cell therapy. When we take your bone marrow and aspirate it, it's a simple procedure. Dr. Ambach will talk about it. That's more of a soup. It's not just stem cells. There's about 20,000 stem cells in a treatment, but there's also a lot of platelets. So it's kind of like PRP in a way. And then there's some molecules that I put there that you don't need to care about, but those are anti-inflammatory molecules that live in your bone marrow that have been shown to be helpful for decreasing pain in arthritis or disc problems. This is what's called an FDA compliant procedure. The FDA says, we're not as worried about this. These are your own cells being used for you. You're not processing them in a way that we're too worried about. And if it's done by appropriately and done by a physician who has, the appropriate training to do this, then we're okay with it. You follow these rules, great. And guess what? There's a lot of data on the safety and efficacy, and Dr. Ambach will go over that for us. Now, what's happening is the legitimate science on the left is being hijacked by the right. And the thing on the right is donor birth tissue products, things like umbilical cord blood or amniotic fluid or placenta. These are obviously donor tissues, right? I don't have my umbilical cord anymore, so somebody else's umbilical cord. We get these companies, these representatives, these salesmen knocking on our door. They're not allowed in our office. They knock on our door. They want to sell us stuff like this. And they get through to clinics, other doctors' clinics, and they tell the doctors, hey, there's stem cells in there. Those doctors don't know that there are not any stem cells in there. If there were stem cells in there, it would be an illegal drug. The FDA does not permit the sale of somebody else's donor cells, stem cells. And furthermore, there's just no evidence for safety or efficacy using these products. Yes, somebody did an umbilical cord stem cell study on a rat somewhere. That's completely different than this product that's being sold at that clinic.
Why is that a product like that not under the purview of the FDA?
It is. It is. But what happens is the FDA says, hey, you have an umbilical cord tissue product, but it does not have any stem cells in it, and you're not exceeding that minimal manipulation. If you want, you can sell it on the market. And so what happens is these manufacturers register this product with the FDA and tell the FDA, we don't have any stem cells in this product. And then they tell the doctor that they're selling it to, there's stem cells in this product. And then that doctor tells their patient, would you like some stem cells? And that's what's going on. And in the next year, you're going to see all kinds of stuff in the news because the FDA is going to, when they're done with this COVID stuff, you know, approving 115 vaccines, they're going to start cracking down on this. Okay, so enough of that. So next slide. Do not get Dr. Rogers started. All right.
Yes, exactly. Well, the only way that patients can get this donor cells would be if they are under an FDA-approved clinical trial.
That's right. Yeah, if you're a guinea pig in a study.
So I have a question from one of the audience members. Talk about getting stem cells from fat tissue.
Yeah.
And then also about Regenx products specifically. Those two things, you can just quickly talk about your thoughts on those.
Okay, so I am medical director for a company called Personalized Stem Cells. Feel free to go Google it. Personalized Stem Cells is a sponsor for FDA-approved clinical trials of stem cell therapy from fat. So we have two studies right now, one for knee arthritis and one actually for COVID that we got FDA approval for, which is kind of cool. We're going to be treating COVID patients. Well, I won't, but our pulmonologists in the ICU will be treating COVID patients with a cultured fat-derived stem cell product that we manufacture at a facility here in San Diego. And that's all through FDA approval. So you can't get this, right?
What about autograft fat tissue? So you take out a bunch of fat from me and then isolate the stem cells and give it back to me. Is there any difference from taking autologous products from fat versus bone marrow?
It's very similar, as long as you don't exceed that minimal manipulation. So for example, if I do liposuction and I just rinse and wash the fat and concentrate the fat a little bit and inject it into your knee, the FDA says, just like with the bone marrow, they say that's fine. However, if I digest it with enzymes and do all kinds of mad scientist stuff to that fat, the FDA says you are now a drug manufacturer. You need to apply for an application to do an FDA-approved clinical trial. And that's why you hear things about the FDA filing a lawsuit against companies that use fat the wrong way.
Yeah, I think the question is more, if you're not doing an FDA trial, not using donor tissue, but your own tissue, and it doesn't have to go through the FDA, does it matter if that stem cell comes from your fat or your bone marrow? Because doing a bone marrow aspiration is kind of painful and a big deal. Doing fat aspiration kind of killed two birds with one stone, maybe. If it's the same, I can see a lot of people wanting to do the fat.
So when I tell folks I would like to take some of your bone marrow, they kind of lean back a little bit. And when I say I would like to take some of your fat, they go, take all of it.
Exactly. That's why that's the question.
But here's the deal. The reason that we don't inject fat cells into your discs or into your spine is because there's no good scientific evidence that it works. And furthermore, the way that we make the product, the way that we rinse and wash the fat, it would be a little bit difficult to inject into the spine. Bone marrow and PRP, they're very liquid-like. Fat's kind of clunky like butter. So I don't really want to inject butter into your spine. We inject bone marrow or PRP. So it's really, the science isn't there yet for fat in the spine. However, a lot of our patients have done very well when we inject that fat, their own fat, into the knee joint when you have knee arthritis. And long story short, I'm publishing a paper. It's going to get done by the end of this year. 192 patients, average age 70 years of age, severe knee arthritis, trying to avoid knee replacement. 92% of them were able to avoid knee replacement at 3-year follow-up.
Wow.
So retrospective study, obviously we need placebo-controlled trials, but to your point, fat is amazing. It just has to be used in the right method for the right problem.
So to answer your question, we're not using fat yet for the spine, but we are using it for joint arthritis and for tendon injuries.
Yeah, it's magic in tendons. We have ultrasound and MRI pictures of before and after, with tendon tears. It works great for that. But I thought we were going to focus on spine, guys. So,
Yeah, move on, move on.
Move on.
so this slide here, you know, sorry, sciencey guy, you're gonna get some science from me. So Mesoblast did a phase 2 study. This is a prospective randomized clinical trial. And they basically asked at 1 year follow-up, after getting this cultured stem cells, 6 million or 18 million injected into your disc for disc pain, chronic low back pain, how many patients are at least 50% better? And you can see about 50% were 50% of the patients were 50% better at 1 year when they got 6 million. I included this slide because it debunks the myth that more is better. 18 million cells actually did worse, 33% patients responding versus 48%. And then you see the placebo control in the blue there, the saline, some of them got better, but not too many. Okay, so that's what science looks like. That's what stem cell science looks like. But we're talking about bone marrow concentrate and PRP. So next slide. And by the way, do not try this at home. There is a right way to inject the spine. You know, Dr. Ambach and I have been doing this for decades. Notice that everybody's in blue, which means everything's clean and sterile. Notice we have some camera equipment so we can see in the spine. Notice that we're board certified and fellowship trained, so we know what the heck we're doing. And we don't do this on everybody. You know, we probably less than 1 in 10 patients actually gets this. We're very selective in who gets this and who gets something else. On the left there, you see Linda. She's in the hood there. She's making the PRP. So we have protocols that we've developed that are customized for each patient. And then I'm actually in the lab. You can see that picture. I'm in that lab. We see all our centrifuges for different kinds of PRP that we would want to make. Okay, next slide. This is a discogram. It's not a dance. This is, you know, Dr. Kim knows about this because if he had a patient that he thought he might want a fusion and he wanted to make sure he knew he was fusing the right segment, we would go ahead and stick a needle in this poor patient's spine. On the left, you see the x-ray, the needles going into the disc. And then notice those 3 little black areas where the dye that we injected is in the middle of the disc in that nucleus. And then that middle one where that red arrow is showing a leak. The contrast is leaking out of the disc. Why? Because there's a tear in that disc. And guess what that patient says when that leaks? Please stop injecting that in my disc. It hurts. So we stop. But this is how we know that annular tears hurt. We don't do discograms so much as we used to, but this is the method by which you get cells into the disc. Next slide. Now this is what you don't want. Remember I told you about those charlatan stem cell clinics out there? I stole this picture from a black market video of a doctor teaching other doctors how to inject the disc with stem cells. What's wrong with this picture? He's not wearing gloves. He didn't sterilely prep the patient's back. The needle's not the right needle. He's injecting donor birth tissue products that don't have stem cells in them. This happens, I cannot tell you, we see a patient at least once a month, spent $8,000 for this bogus treatment. Please do not fall for this. Okay, enough of that. And then who's not a candidate? These are the folks that Dr. Kim can help. Patients with severe disc degeneration on the left. Patients with severe stenosis, that's where the nerves are getting pinched. He can unpinch them, I can't. Or on the right, spondylolisthesis, great word. That's where that bone is, that disc is so degenerated and that segment is so unstable that now the spine is misaligned. Those folks do great with spine surgery. So they don't get cell therapy. All right, enough of me. Time for Dr. Ambach.
So now
that was awesome.
That's great, Dr. Rogers. Thanks for
Okay, I have a question. If people cannot easily find or don't know how to look for FDA-approved trials or for stem cells, what are there alternatives that are legal and actually help severe back pain?
That's what Dr. Ambach's going to talk about right now.
Okay.
So Dr. Rogers
I just asked that because I got a little piece of paper. We didn't plan that at all.
Great segue. So now I have the fun part of discussing the evidence for these therapies. And there's several of these clinical trials, but we've just cherry-picked some of the trials to present to you. So this first one is a systematic review. A systematic review is a collection of different clinical trials, and they make an analysis and make a conclusion out of it. So on the left, you can see they assembled 5 different clinical trials totaling 90 patients for a follow-up of up to a year for PRP studies. And on the right, you can see they did a systematic review of all bone marrow clinical trials. There's 7 that they included in the study, 97 patients and up to 72 months of follow-up. And their conclusion was the same for both systematic reviews, wherein there was significant improvement in the pain and function in these patients that were treated either PRP or bone marrow injected into their discs to treat their low back pain. And also, more importantly, the procedure was safe. There was very low complication rates or adverse events from these procedures. This is one of the more important studies for injecting PRP into the disc for disc degeneration. This was a study of 47 patients. It was a randomized controlled trial, so a really high quality study wherein they did 1 injection of PRP into the discs. Now, some patients received 1 disc injection, some patients received several discs that were injected at the one time. And all these patients were followed up to 2 years, and they have shown that the PRP treated patients had improvement in their pain, their function, and also in their patient satisfaction. So they followed their, and by the way, these patients were compared with the control, which is saline. They followed these patients more so up to 9 years, and they found that the improvements were maintained up to 5 to 9 years, which is pretty amazing. I can't remember of any spine injection that we do that we can say can last for 5 to 9 years. We published a clinical case series about 2-3 years ago of 20 patients that we treated PRP and bone marrow cells. The less degenerated discs was injected with PRP, and the more degenerated disc we injected with bone marrow cells. And the more severe pathology, we decided to treat with bone marrow because of the cellular mediators that were in there, as opposed to the growth factors and the platelets from PRP. So we found that at 18 months, 93% of these patients showed more than 50% pain relief and improvement in their function. A secondary objective of our study was to evaluate the utilization of healthcare. And we have shown that 80% of these patients decreased their use of their pain medication, and none of the patients that received treatment went to the ER or got hospitalized or had to go through a surgical procedure.
Can I interrupt for a second on this slide? Go back to that slide. Dr. Kim, next slide. So Dr. Ambach and her colleagues showed that 93% of patients showed at least 50% improvement in their pain and function scores at 18-month follow-up. That's using your own bone marrow cells. Remember, I told you there's only about 20,000 stem cells and a lot of platelets and other stuff. What did I say the success rate was for the using somebody else's stem cells? 6 million or 18 million cells in that study. At 1 year follow-up, remember I said only about 50% of patients got better than 50% relief. So this really tells you that maybe there's more to stem cells than just stem cells. Maybe it's the soup. Maybe the bone marrow has a whole bunch of other stuff in it that is more effective than just the stem cells.
Yes, and studies have shown actually they're trying to now tease out all these other proteins and molecules that are in the mix, and they're trying to show their specific effects on disc degeneration and other orthopedic injuries. So
this is why we're talking about this topic, because I know that if everyone's like paying attention to the references, you'll notice that the years are like 2019, 2020. This is relatively new. I'm learning a lot just listening today, and the goal is to, those 20 patients are the 20 patients that don't want an operation, like a traditional spine operation. So if they weren't part of this kind of treatment, they would just be smoldering along in misery for a long time. So that's why this is so important. We need this gap-filling strategy to take care of patients that are bad enough to have their function and quality of life affected, but not so bad that they want a big spine surgery. And for many, 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 many years, we've just not been able to take care of those patients, and essentially just wait for them to get bad enough, or either better or bad enough to do one of two things, and not actually dealing with their current problems. So this is quite impressive, the data that's coming out.
So we like pictures. This is one of the patients that was enrolled in the study who had an annular tear at L4-5. And as you can see, there's this white signal where the arrow is pointing. After one PRP treatment, that annular tear resolved. Now, some would question, would that annular tear just resolve on its own without treatment, right? At 6 months, that's pretty quick for it to resolve. Usually it takes, about 18 months, 2 years for annular tears to get better. So, did the PRP help, increase that healing process and accelerate the repair? Maybe. So this is a study, this time using bone marrow cell therapy for disc degeneration. And they enrolled 26 patients, all of whom were candidates for disc replacement or fusion. And for many reasons, they did proceed with the surgery. So they enrolled in the study. The average improvement in their pain is 73%, and the average improvement in their function was 69%. Out of the 26 patients that enrolled, 6 eventually underwent surgery. So 75% of them was able to avoid surgical intervention. This is up to 3 years of follow-up. And also they did an MRI 1 year after the injection, and it showed that 40% of the patients, the MRIs that they have seen showed an improvement of their disc degeneration of at least 1 grade in the Furman rating. So right now I am a part of this multi-center randomized controlled trial study wherein we wanted to compare PRP and bone marrow for disc disease. There are several trials now that has been published regarding PRP for disc disease and bone marrow for disc disease, but this will be a pilot study that actually compares these two biologics head on. So there's 4 centers across the United States, and we're planning to enroll a total of 60 patients, 15 patients at each site. And these patients are going to be randomized to one of 3 groups. The control will get the trigger point injection into their muscles. The active arm will consist of either a PRP treatment or a bone marrow cell treatment. And the beauty of this study is there's a crossover design, which means that the patients who receive trigger point injections, if they're not better after 3 months, they get crossovered to get one of the active treatments of either PRP or bone marrow. And in the same way, the patients who receive PRP treatment, if they're not better at 6 months, they get crossovered to receive the other cell therapy, which is bone marrow, and vice versa. Bone marrow patients not better at 6 months get crossovered to receive the other cell therapy, which is PRP. So that will give us a lot of data to analyze and compare these two. And we're going to be following these patients for several months, assessing their function, pain, and serial MRIs. So we have right now a partial result of several patients at 6 months, and so far our outcomes are pretty good. So
is this an FDA study, or is this just a regular study?
This is the RCT. It's IRB approved. It's not FDA sponsored.
Yeah, remember FDA doesn't regulate PRP and bone marrow.
Right, and bone marrow.
It does the drug.
Right. Okay. So to answer the question, if you want to get stem cell therapy and you can't participate in an FDA trial, you can get the therapy by using your own bone marrow aspirate, combining the PRP from your own aspirate and the bone marrow from your own aspirate, and injecting it back into yourself. Then you can get this therapy without being involved in an FDA trial.
Yeah, that's what we do. That's what we do every month. We treat, probably 4 or 5 patients with this every month. And
would you say most of your patients are in a non-FDA kind of treatment, or most of them are in an FDA trial that get PRP/stem cells? Stem cells.
Yeah, our spine patients are not enrolled in a clinical trial, except for this IRB approved trial.
And anybody can just see you and get this treatment potentially.
That's right.
Correct.
Okay. They don't have to enroll in an FDA trial, which.
Yeah.
That's correct.
Right.
And by the way, these are the same day treatments. So you come in the same day, we aspirate your bone marrow or we get your blood, and you get the treatment in the same day.
So you guys aren't enrolling patients. You're just taking care of patients, and along the way, you're collecting information so that you can have data.
That's correct.
All right.
Yeah, we have other studies, but for the spine That's true.
I think the questions are related to people that are seeking this type of treatment, and they're worried that they can't get it unless they're part of a clinical trial through the FDA, which you can't just enroll in an FDA study just because you want to. Whereas if you're part of a, like you're keeping track, you have your own internal study, and it may even be funded as a study, but it's part of just taking care of patients, right?
That's
That's
right.
correct.
Right.
So this talk is focused on disc, but there's also other spine pathologies where we use PRP and bone marrow for. So you may have heard of epidural cortisone shots to treat your sciatica. We use, instead of cortisone, we can use PRP into these patients. And you can see 3 of these clinical trials I included in here. And all these patients had improved in their pain and function, whether it's just low back pain or it's low back pain with sciatica, after we injected PRP epidurally instead of cortisone.
Yeah, and we can just say, usually we'll try a cortisone shot first, although it's kind of falling out of favor among those of us who are in regenerative medicine. I don't know if anybody in San Diego has done more epidural steroid injections than I have, and that's not something I'm necessarily proud of because I think that's old school and passé, but it does help people, right? And so we try it first, insurance pays for it. But what we find is that it doesn't last very long, typically, the epidural steroid injection. And so we find that the PRP will last longer than the steroid.
So this one is also the use of PRP for facet joint pain. You're familiar with the facet joint. These are the little joints that connects the little segments in your spine, and they can hurt either from arthritis or if your spine is a little bit out of alignment. Right now, the traditional treatment, just like for sciatica, is cortisone injection, which can work, can last you maybe a couple months. This study actually compared injecting PRP with steroids and local anesthesia. And they found that for the first 3 months, 2-3 months, the steroids did give better relief. But after those 3-6 months, the PRP actually had more sustained relief, more patient satisfaction, and less disability in these patients. So the PRP was superior in yielding a longer duration of relief.
I don't know if you're going to get to this, but there is a question about the sacroiliac joints, and it looks like that next slide has sacroiliac joint in there.
That's perfect segue.
That is so weird.
So SI joint pain, SI joints are these big joints that connects your pelvis and your low back, and they can be a source of pain for up to 30% of patients who's got chronic low back pain. And again, traditional treatments are cortisone injections or maybe nerve blocks or a radio frequency ablation where they burn the nerves that provides a sensation to these joints. These SI joints, they're huge joints, and they have a lot of ligaments that support them. So for us to be effective in treating SI joint pain, which is typically associated with SI joint dysfunction, wherein there's ligament laxity that's involved, we not only treat the joint, but we also treat the ligaments that support it. We need to stabilize the SI joint. So that's what we do when we use PRP for the SI joint. We inject it to the joint to help decrease inflammation, avoid arthritis from setting in, but we also inject it into the ligaments around it to make it more stable and strengthen the ligaments. This is specific study compared steroid injection with PRP, and as you can see on the right here, I can't see it in my slide, but there's 90% pain decrease with PRP use compared to 25% after a steroid injection. So, in an effort to provide the best patient care and also to help move this field forward, we are tracking our outcomes and we track them through a regenerative medicine registry that we call Data Biologics, which is co-founded by Dr. Rogers. And it helps our patients make informed decisions. When they come to us and tell us what are your outcomes for, the PRP injection into the disc, we can pull up our data. It's same day. We can pull up how many patients we've done, and we can tell them specifically, for what condition and what are the results. For example, this is a snapshot of 48 patients we've treated with low back pain, and we treated with biologics, had decrease in pain, over, this is more than a year and a half. And it just gives them an objective data on what our outcomes are, and it gives them a better informed decision. This is another snapshot wherein, 10 patients that receive a certain treatment into their low back had an increase in function after about a year. So it's also, it's good to collect data so that hopefully this can be a collection of information that we can hopefully use for insurance companies and other regulators to help guide them to make future decisions. And also it helps to standardize protocols with a new therapy such as this.
All right, we're right. Oh, perfect.
That's it.
Wow, we are cosmically linked, because I was about to interrupt you and say, we're running out of time. So, all right, so it's pretty clear that there's a lot of promising positive data related to PRP, stem cells, and the whole area of orthobiologics or biologics and regenerative medicine. So what are some of the drawbacks? And I'm going to pull out two. The first is somebody asked, can you get arachnoiditis from PRP injections in the spine? Obviously, if it's epidural, but same thing with stem cells. And then two, you mentioned that you need to collect this data to go to insurance companies. I have the same problem with some of the surgeries that I do that are relatively new. The insurance companies don't pay for it. So can you talk about those two kind of drawbacks and give us an idea of where we're at in terms of what are the drawbacks, what are the limitations, what are the obstacles of getting this treatment for yourself?
There's three key obstacles. The first is finding a physician who actually knows how to do this properly and identify if you're a candidate or not, and make the right kind of biologic and put it in the right place and combine it with the right rehab. I mean, it's like baking a cake. Now, maybe that's not the best analogy, but there's a lot of ways to make it. I can't bake a cake. So that's one issue. The other issue is this is an evolving field. And so physicians all over the world are trying different protocols. They each have their own protocol. We need to learn which protocols are most effective and standardize them so that patients know that no matter where they go, they're getting, the best treatment that has the best evidence to support it. And then the third is we got to get insurance companies to pay for this. And they're not going to do that until we do the first two things. So we have well-trained physicians, certifications for physicians, and also standardized protocols that have good scientific evidence. So we presented the evidence, but I would characterize this as early evidence, right? As you saw, I think the earliest published study was published in 2013. So this is considered, new stuff. And at this point, we have more anecdotal experience with our own patients than there is in the entire published literature. So there's a lot of work that needs to be done, but that work is being done. That's part of why we created Data Biologics. We have over 60 doctors around the world using that registry, tracking their outcomes so we can see what's working best.
I love that you do that, because I don't know if you remember, I've been trying to start a spine registry.
Yeah.
And I can't emphasize enough how important it is for all of us as physicians to keep track of our outcomes and results over time, because if I was a professional athlete, that would be done for me. And
Right.
if I did not perform to a level that is acceptable, I would know that, and I would make steps to kind of get better. And for a variety of reasons, we don't do that. And all you got to do is just keep track of the patients that you take care of and put them into a format, a database, where you can go back and extract information more quantitatively. And after you got about 1,000 patients, you don't need a randomized control trial. When you have enough patients, you can discern information just by sheer volume. So it's so great that you're doing that, because I value a large registry outcome study that represents real world kind of clinical scenarios just as much as a really tightly controlled, highly refined randomized controlled trial where we're comparing patients with a placebo, et cetera. Both types of studies are necessary, but we do so many kind of randomized controlled trials and spend so little time collecting the mountain of information that we get from every day from our patients that come back and visit us after treatment that I wish more people would. We all need to keep a registry, really, Because if we had that, we'd be able to do lots of really refined randomized control trials that answer really specific questions rather than doing all this shotgun.
90% of the patients, 90% of the patients that are getting treated with PRP or bone marrow or even fat-derived cells are not enrolled in a clinical trial. And I just, for years, I thought it was a shame that all that data was being lost.
Exactly.
So this now allows us to collect that data, which will then inform good randomized controlled trials. And so we need both. I want to get to the question the patient had about safety. PRP and bone marrow concentrate have exceptional safety records. I think there's a study, Dr. Hernegau in France, who followed patients for 12 years after a bone marrow stem cell treatment. I'm going to call it a bone marrow concentrate treatment. And he was concerned about causing cancer or any other thing that might happen when he injects these cells. The safety record is phenomenal. There's always the risk with an injection, whether it's cortisone or anything else, of infection, bruising, bleeding. If the person doesn't know what they're doing, they can hurt you. But I have to say, knock wood, in 23 years, I've had 0 complications with anything we've injected into the spine. Arachnoiditis, we've just not seen it. That's something that typically would occur after surgery if maybe there was an infection or too much inflammation. The PRP does not induce arachnoiditis, fortunately. But you know, the real issue is how do we get the best long-term results? And that's where all the science is being focused on now.
Right. And I just wanted to add, Dr. Rogers, with regards to the downsides of these procedures, these are procedures that does not give you immediate relief. So it's not like a cortisone shot where when you get a shot today, you feel great immediately. This will take time. You know, usually you don't see the results from these procedures until a couple months down the line. So that's something that we want the patients to recognize. But once it's working, it will last, and you're in it for the long term. Also, there's the financial risks. It's not covered by insurance. So if you want to call it a downside, you know, you have to pay for it out of pocket. And that's why we need data to support all the evidence and the promising information that's out there with what we're seeing with these therapies.
Okay, I have a question that I have to ask you just because I've been taking care of so many of these patients because I did a few of these surgeries. So somebody asked, an anonymous attendee, that's so awesome, I didn't know you could do that. Can PRP or stem cells help with Tarloff cysts? That is a loaded question. But do you guys have any experience with that?
Well,
or knowledge of that?
Yeah, so Tarloff cysts, for those who don't know, by the way, everything in medicine is named after a doctor with an ego. So we need to find a Rogers cyst or a Kim or Ambach cyst. But anyway, Dr. Tarloff names these things. It's a thing that forms on the sheath around the nerve in your spine. My understanding, Dr. Kim, you probably have more experience, is that these are not thought to be causes of chronic low back pain. I imagine they could be if they were large enough, but we have not treated cysts with biologics.
So that question is interesting because it's the same argument as the annular tear. If you have 100 patients with Tarloff cysts, 95 of them will be asymptomatic.
Yeah.
But for the 5 that aren't, it's 100% for them. So that's a whole nother group of patients that literally have been completely marginalized to the point where there's at least 3 Tarloff cyst support groups that are massive.
Oh,
and
wow. Great.
If there's a lot of Tarloff cysts out there, which there are, even a small percentage of them that are symptomatic constitutes a large absolute number of patients. So we have to be careful not to start creating disease states that don't exist and treating patients that whose diagnoses don't really match up with the surgery. But I'm pretty certain, based on what I've been seeing, that this Tarloff cyst story is very similar to the annular tear story, where we as physicians have decided most people with Tarloff cysts are asymptomatic, and therefore Tarloff cysts should not cause symptoms. But if you just sit down, sheer logic would dictate that makes no sense, because if you do have symptoms, it's 100% for you. So if you do have a Tarloff cyst patient and you can confirm that they are symptomatic, I'm just thinking, because Tarloff cyst surgery, if I never did a Tarloff cyst surgery for the rest of my life, I would be very happy. That surgery is like, I'm going to take gum out of shag carpet today. This sounds really fun. It is tedious. It takes forever. It's annoying. And we barely get paid anything to boot. So it's really
I'm so
a
glad
huge
we have
need.
doctors I'm so glad we have doctors like you that can do those things when we
All
can't.
right, we have 2 more questions, even though we're supposed to stop. But let me just try to get people, because I don't want to go over 5 o'clock too much. It's already 5:07. So can I say the following? Can I just have each of you just say something short real quick at the end? And then for those of you that will have more questions, is it okay if they contact you by email or call with additional questions?
Is our information there on the screen? Can everybody see
If you say you can, then I will give them your email.
The email is not there, but it's admin, ADMIN @sdomg.com.
All right, so when this is all over, all the people that registered and attended whose email was given to us, we'll say thank you, and we're gonna put in your email address.
Sounds good.
Is it? Lana has it. So do you wanna say a couple of things, Chris and Annette, and then we'll sign off?
What I'm gonna say is I'm really optimistic about the future, whether it's using your own cells in the form that we're doing now, or some new FDA approved treatment, some biologic, whether it's a cell or something else. There are so many cool things that are being worked on right now. We are just touching the tip of the iceberg. And this is necessary because, as Dr. Kim said at the top of the program, so many people are suffering needlessly. They've tried things that are non-surgical that aren't working. They don't want surgery, and they're stuck in this gap, this zone. And I see these patients every day. And before we had these tools, there was much I could do for them other than empathize and educate them and just help them cope. But now we actually have ways we can resolve the issue. And I think it's just going to improve as we go forward.
Yeah, I concur. You know, Dr. Rogers and I, we were already in practice, and we see these patients day in and day out with chronic spine pain. And there's just so much we can do for them. You know, they don't get better. We just keep doing the same thing over and over again. And that's why we got into this regenerative medicine field, is that we actually want to make the structures better. We actually want to improve the condition and treat the condition. And I think that's the promise of this field. And that's why we're very excited, because the data is very, very promising. And I think we can do lots more with it.
Yeah, I feel exactly the same way, even with surgery, because I don't know if you know, and I don't want to make this the topic of the discussion, but I do a laser endoscopic surgery, and I've noticed that the patients with annular tears that don't get better with non-operative treatment, and I have to admit, I didn't know enough until today that PRP and stem cell products are working so well. I would try that first, but the laser endoscopic surgery, where you just go in with a tiny little poke hole and use an endoscope and do underwater surgery using lasers and tiny little instruments to treat that little annular tear, that's been working out really well too. But that's surgery. You know, if you just take all that into consideration today compared to 10 years ago, it's like we've had this like awakening of identifying patients that really need our care and having some tools where we can actually help them. So I agree with you. It's a really exciting time in spine. It's still early, so I don't want to give people the idea that we fixed this problem, but this is the first time where I'm sitting down thinking we have a legitimate promise to take care of a very large group of patients that have been suffering kind of silently for many years. So I agree with both of you. I'm very excited, and that's one of the reasons why we're doing this. So thank you very much. Thank you to all the attendees. Keep an eye peeled for your email. We will send you a link to the recorded video so you can share it with any friends that didn't know about this but are in the same boat. And that email will have contact information for Dr. Rogers and Ambach and me, obviously. So if you have any further questions, that would be a good way to stay in communication with us. And we'll do our best to kind of answer everyone. Sound good?
Great. Thank you so much for having us.
All righty.
Thanks, Dr. Kim, for having us.
Have a great evening, everyone, and God bless.
You too. Bye-bye.